So I'll pass it on to you, Jill.
Thanks very much, Ray, for the introduction, and welcome everyone to our online forum. We're really thrilled to have you with us, and I know that this event spans many time zones and countries and jurisdictions, so I think we'll have people sort of coming and going through the event. We encourage you to stay with us the whole time, and we're happy to have people from all across the region. I just wanted to start by acknowledging that the University of British Columbia, where Dr. Lam and I are based and others, is located on the traditional and unceded territory of the Musqueam, Squamish, and Tsleil-Waututh nations, and we're grateful to live, work, and play here. I also wanted to start by giving some acknowledgements for the people that made this event possible. First of all, Rosie Tran, who is a research assistant with us, has done an amazing job and worked really hard to really help coordinate all aspects of this event. So thank you very much, Rosie. She's only been with us for 2 months and has done a fantastic job. So we really appreciate you. Vanessa Evans is a research manager with the APEC Digital Hub for Mental Health and the Mood Disorder Center here at UBC. And thanks to Vanessa for all her support. We'd also like to acknowledge and thank the Public Health Agency of Canada and the International Health Grants Program for support for the Digital Hub, the APEC Health Working Group and Ms. Aurora Sai, the speakers today who are joining us from all across the APEC region, and we're really grateful for their time and support and are really looking forward to hearing their perspectives. And of course, we'd really like to thank all of you as the attendees of this event. I'm not going to take too much time, but for folks that are not familiar with the APEC Digital Hub for Mental Health, I'd just like to introduce us briefly. So we were created in 2017 under the 2014 to 2020 roadmap to promote mental wellness in a healthy Asia Pacific. And our mission is really to enhance awareness, share knowledge and experiences, develop customized curricula, and facilitate model partnerships across the APEC region. With a view to strengthening mental wellness in the support of sustainable economic growth and meeting the needs of APEC member economies in alignment with APEC with international best practices. And you can see on the slide our host consortium, which is made up of the University of British Columbia, as well as the University of Alberta and the Canadian Network for Mood and Anxiety Treatments, or CANMAT. And the blue dot, on the blue dots, you can see a number of our core partners across the region. And the hub is really essentially a network of policymakers, researchers, clinicians, and people with lived experience from across the region. And our strength is really found within our membership and our network. And I'd like to also introduce our team, many of whom you'll see throughout the program today. So you've already met Dr. Raymond Lam, who's our executive chair, and me, I'm the executive director. With us on the call as well is Dr. Erin Mahalik, the program director, who's a professor in the Department of Psychiatry here at UBC. Dr. Andy Greenshaw, who's the scientific director of the hub and is professor and associate chair of psychiatry at the University of Alberta. Dr. Chi Eng, who's a steering committee member at the University of Melbourne, and Dr. Arun Ravindran, also a steering committee member and professor in the Department of Psychiatry at the University of Toronto. And Ms. Vanessa Evans, as I mentioned, is our research manager, and Ms. Rosie Tran is our research assistant. And I'd like to, because this is a webinar and we have a lot of participants, we don't have time to do a round of introductions, but I would encourage you all to share in the chat where you're from and where you're joining us from today, and a little bit about yourself if you're so inclined, so that we know who's out there and who's joining us today. This forum is really intended to bring together members of the Digital Hub Network, as well as members of the general public and people who are interested in the topic of mental health equity across the Asia Pacific region. And this work is really situated within the 2021 to 2030 roadmap to promote mental wellness in a healthy Asia Pacific, which identified the need for investment in mental health and well-being to support health and economic prosperity in the APEC region has never been more urgent. And the roadmap was drafted and tabled to APEC Fora in 2021. And the development was led by us at the Digital Hub, but it was also a very collaborative effort. So you can see on this slide We held a roundtable in Singapore that was hosted by the Institute of Mental Health in Singapore, where we worked with our partners to identify priorities going into this, this roadmap. And we produced a document called APEC Digital Hub for Mental Health Next Steps Roundtable Report, which really informed the development of the roadmap. And the roadmap was also informed by members of the APEC Health Working Group's sub-working group on mental health. So it was definitely a collaborative effort and captures a lot of the priorities of stakeholders across the region. And I'll just give a high-level overview of what's found in the roadmap, and you'll see that it really aligns with the objectives of today's forum. So we have one overarching goal, which is to take a principle-driven approach to all the work that we do as the Digital Hub and within our network. And these principles include diversity and inclusion, engagement, so bringing together stakeholders across APEC member economies, which we're doing today and beyond. Ongoing learning, so a big objective of today's event is to learn from our partners across the region in terms of best practices and the great work that they're doing in their economies in terms of promoting equity in mental health and well-being, and taking a strengths-based approach. So this also really aligns with the objectives of today's event, which are to acknowledge and capture the assets and strengths that all member economies and stakeholders bring to implementing the roadmap. So you can see that we have a number of cross-cutting themes that align with our second goal of focusing efforts and scaling up initiatives for maximum impact. And especially relevant for today is the cross-cutting theme of digital technologies. So of course, we look at the role that digital technologies can play in all the work that is happening in the region to promote mental health and sustainable development, as well as equity, diversity, and inclusive growth. So we have a real mandate to understand how we can do better at promoting mental health equity in the region across all of the work that we do. And then finally, I wanted to just raise our priority focus areas within the roadmap. And you can see that we have several, many of which will be touched on by our speakers today. So I hope you enjoy the presentations that will touch on a lot of these priority focus areas. And I'm really excited to learn from our speakers about the amazing work that they're doing in their own jurisdictions. So I don't want to talk too long, so I just want to give a quick overview of some logistics and housekeeping before we go into the actual forum. So the event is being recorded, just so everybody's aware. The format includes 2 mini plenaries, so these will be 20-minute presentations, on one by me and one by Dr. Anil Thapliyal, relating to topics of digital mental health equity. And then the other panels, which we have 3 lightning talk rounds. So the lightning talk format really gives an opportunity for speakers to give a very brief, quick presentation identifying best practices and initiatives from their own organizations and jurisdictions. So these lightning talk rounds will include panels of 3 speakers who have 7 minutes each, and we'll have a quick round of questions. And so each of these will be moderated by a member of the Digital Hub executive. And we really want to encourage a lot of questions and discussion within the webinar format. So if you have questions, comments, or want to raise issues, please feel free to use the chat box or the Q&A box, and the moderator for each session will facilitate the question period. And we'll be taking a 15-minute break at 5:45. I realize this should say PDT, Pacific Daylight Time, here in Vancouver. So we will be taking a break in this very packed program. So I think that's all I have to say in terms of introductions to the program and to the Digital Hub. Again, feel free to put your comments and questions in the chat or the Q&A box. And we're going to go on to the first plenary, which is actually by me. So I'm going to just switch up my slides and we'll get right into it. And I'm going to, for our first mini plenary, I'm going to spend about 20 minutes talking about the results and recommendations from the Technology and Equitable Access to Mental Health in a Post-Asia Pacific or TeamCAP study. So the TeamCAP study was initiated early in the COVID-19 pandemic, so in 2020, and it was funded by the Canadian Institutes of Health Research in response to two trends, and this was led by the APEC Digital Hub for Mental Health's Disaster Resilience and Trauma Working Group. And as you can see, our study team is diverse and made up by folks here at UBC, as well as across Canada, in Australia, in China, Chile, Malaysia, South Korea, Vietnam, and the United States. And many of the co-investigators are with us today on the forum and will be speaking as well. And this was really a response to the rapid shift to digital technologies during the early stages of the pandemic, and concerns related to digital mental health equity in this context. So I'll start by giving some study context and objectives very quickly. So of course, mental health equity concerns and access to mental health services predate the pandemic. So we know that mental health systems are often stretched, and a lot of folks have trouble accessing mental health, and this has been a challenge across the world and across the APEC region long before the pandemic. But these challenges around equity related to mental health risk and differences in access to mental health were really compounded during the pandemic. And as you know, in the context of early pandemic precautions and restrictions, there was really a rapid shift to the use of digital mental health technologies such as apps, websites, telehealth, video chat, conferencing, things like that. During the early pandemic. And as I said before, this really raised concerns about equitable access in terms of populations that may not have ready access to digital health technologies. But we also recognize that the pandemic, because it really accelerated the uptake of digital mental health in a way that had never happened before, is a real opportunity to learn from this experience and to inform the equitable delivery of digital mental health as part of mental health system strengthening going forward. So that's the context of the TeamCAP study, very briefly. And the objectives, the first of which was to conduct a needs assessment and identify priorities related to digital mental health equity among at-risk populations in the APEC region during the first year of the COVID-19 pandemic. And we mean at-risk population in terms of populations that are more likely to experience negative health impacts as a result of the pandemic and its related socioeconomic impacts, as well as populations that are at higher risk of experiencing barriers to mental health care and digital mental health access. And also to identify recommendations to inform future policy and practice for equitable digital mental health in the region. So we had 4 broad research questions, and the first was to understand which populations are most at risk of experiencing barriers to digital mental health access. The second are what barriers do these populations experience? What are the barriers to actually delivering equitable digital mental health support? And finally, which resources and actions are needed to improve equitable access to digital mental health? And of course, these are very interrelated questions. And a brief overview of our methods. So we collected data between June 2020 and April 2021. So this took place in the very early days of the pandemic. We used a mixed methods modified Delphi consensus methodology. And our objective wasn't to come to a complete consensus. And this is why this was a modified approach. But we wanted to use this methodology to undertake a process of prioritization around some of these challenges and recommendations with stakeholders from across the region. So we conducted online consultations and surveys with policymakers, health and social service providers, and people with lived experience, and I'll say a little bit more about those in a second. One limitation of this study is that, at least in this part of the study that I'm describing today, we only collected data in English because of resource and capacity restrictions. We did collect similar data in Vietnam and Vietnamese, and this data is currently being analyzed. And we'd intended to collect data in a couple of other countries, but the pandemic demands and restrictions just made this logistically too challenging given the time frame. And for analysis, we used descriptive statistics to analyze the survey data and thematic analysis to analyze the qualitative consultation results. So for our online consultations, we consulted with 8 policymakers, 7 service providers, and 8 people with lived experience. And many of these participants played different roles and wore different hats. We had many people with lived experience who also provided services or were policymakers. You'll see that when we display the results that they have many different perspectives. And they represented Canada, Chile, Malaysia, New Zealand, the Philippines, Russia, South Korea, and the United States. And we also conducted an online survey, which we disseminated widely using various channels. And we, after cleaning for bots and spam, we were able to use 2,151 responses. And we had responses from all APEC economies, but you'll see that we did have a very high concentration of responses from English-speaking Western or English-speaking high-income countries, including the US, Australia, and Canada. And our study sample was made up of just about 44% providers, and these include both mental health and healthcare and other healthcare providers. People with lived experience and their family members or caregivers made up 22.5%. Policymakers made up about 13.5%. And community organization representatives made up also about 13.5%. So before I get into the specifics of the results, I think this quotation from one of the policymakers really sums up the work that we're doing very nicely in terms of the impact, the mental health impact, and the service access impact of the pandemic. And they said, I think the main finding from the work that we're doing in communities is that people who previously experienced health and social inequities are the people who are hardest hit. So in terms of results related to our first research question around people experiencing barriers to digital mental health access, you can see from the survey results that our most highly ranked barriers include people living in rural or remote areas, people living with severe mental health conditions, Indigenous populations, and people experiencing poverty. And then in terms of feedback or findings from the consultations, we also heard a lot about the barriers to people living in rural and remote populations. So this service provider from Malaysia says, in Malaysia, we've seen that the people that really could not get digital mental health and telehealth care are people in the rural areas. So if we want to provide virtual mental health over there using digital technology is going to be very limited access for them. People with low socioeconomic status were also identified as experiencing barriers. And one person with lived experience says, people in poverty who don't even have a computer or a phone. Yeah, I see it all the time in my work. So many people, they can't even access our services because they don't have a laptop or anything that's required. Ethnocultural and linguistic minorities were also identified as a service provider described. The service provider is from the United States, and they said, the other group is the non-English and non-Spanish speaking population. Unfortunately, it seems harder to have interpreter services while providing any form of virtual care. And when somebody's sharing sensitive information, that adds a level of interpretation, and the barrier to it makes it harder. And finally, seniors were also identified as a population experiencing barriers, with one person with lived experience saying older people who are not very tech savvy and who don't know how to use technology, even if they know how to use basic social media, they don't know how to settle into that modality of talking to someone over the phone about such heavy issues. So next we have results related to barriers to digital mental health access. And there's quite a lot of overlap between the previous slide and this slide in terms of what populations experience barriers and the specific barriers they experience. So you'll see from the survey results, over half of the survey sample identified limited or no internet connectivity, as well as the high cost of accessing internet and the cost of e-mental health programs in general as the top 3 priorities or the top 3 most significant barriers to accessing digital mental health care. And then from the consultations, we also heard about the barrier of linguistic and cultural appropriateness. So we had one representative from the Philippines who says, as I see it here in the Philippines, the indigenous people who live in the mountains, remote areas, not only because they don't have a phone, but because of language and cultural expression. Accessibility was also identified as a barrier to digital mental health access, with one person with lived experience saying you have individuals with hearing impairments that may not have the right devices to do an online meeting, and those that can't just log in without their support worker or family member right beside them to use the devices. There were also privacy and safety concerns. So these concerns related to people who, in the early stages of the pandemic with stay-at-home orders, may have been in small spaces with children, with partners, and couldn't access services privately, but also populations that may actually have faced threats to their safety by accessing mental health services from home. And in this example, we see a person with lived experience talking about LGBTQ youth. Maybe they're not in a super supportive home environment, and being in a situation where they're stuck at home for long periods of time with parents who maybe aren't affirming and maybe don't even know their identity is really dangerous. Finally, the issue of trust and the therapeutic alliance was also identified as a barrier to access, with one policymaker saying mental health care often is correlated to kind of trusting relationships between the recipients of care and the practitioners, and cultivating trust through virtual means is much more difficult. We also asked about barriers to digital mental health delivery from the delivery side. And in terms of the survey, this issue of the trust and therapeutic alliance was rated the most highly by our survey participants in terms of provider concerns about therapeutic alliance. Also, providers finding it hard to pick up nonverbal cues, so in terms of body language and communication, and then having concerns about privacy, security, and confidentiality. From our consultations, we also heard about challenges related to the capacity to provide culturally and linguistically appropriate care. So this person with lived experience, who's also a service provider, said, as we explore these different ways to be more accessible and better serve different vulnerable populations, we come up against capacity issues all the time. The issue of low provider confidence in digital mental health approaches was also raised, with a service provider saying, the most significant challenge is resistance from the mental health providers, and not resistance because they don't want to, resistance because they're afraid of lack of confidentiality, that we won't be able to provide the strong bond. So again, you hear themes about confidentiality, but also about the therapeutic alliance. And then a lack of guidance or frameworks to inform best practice around offering care digitally or virtually, with this service provider saying, when my work had to transition to providing counseling services online, there were all these questions of like, which platform do we use in terms of confidentiality? And there were a lot of different conversations and confusion around confidentiality with the actual platforms. From our perspective as service providers, it was really confusing to know what's compliant and what isn't. And then finally, a low awareness about digital mental health availability, quality, and effectiveness from the perspective of providers. So one policymaker says, so with the first challenge around quality, we heard just so often that in terms of prescribing different applications, and so I'm not talking about the telehealth side, I'm talking about specifically about programs online, not knowing what's based on evidence, what's going to work for a particular audience, age group, etc. And we also asked what resources and actions are needed in order to better promote equitable access to digital mental health across the region. So from the survey, providing culturally appropriate and safe services, as well as services in multiple languages, were ranked as the most important resources and actions needed. And then in terms of our consultations, we heard recommendations for improved cross-sectoral collaboration. So this person says, for example, the newcomer settlement sector, collaborating with doctors who often need to provide referrals to patients, collaborating with the government sector. So various sectors need to be more cohesive in terms of what they're providing to the at-risk populations. We also heard about the general challenge of affordability of mental health care, which which also involves and implicates digital mental health access. So this policymaker says, meaning there needs to be a greater range of services available for free at point of use. Because right now we see programs that are free for mild to moderate symptoms, and people can access our public healthcare system to see a psychiatrist or be admitted into intensive treatment but that middle ground of counseling and different forms of evidence-based therapies is still paid out of pocket or through insurance. For a lot of at-risk groups that may be living in poverty, it's just completely inaccessible. And I believe this policymaker was Canadian, so they were talking about the Canadian context, but I think this really translates across the region. There's also a need for improved awareness about digital mental health. So this policymaker says, the number one thing we learned when we were asking patients and practitioners around why didn't you use e-mental health? It was really around not only did they not know the services existed or the quality of the evidence, the number one thing was that they thought it didn't work as good as in person for whatever they came in for. And so there's also some myth busting needed. And finally, the need for national guidelines and frameworks to guide the implementation of digital mental health. So, and again, a policymaker says, I'd like to see that we work towards having some e-mental health framework for our countries, some framework that allows us to do the procurement in the right place, at least with our federally funded initiatives. And they say that as a nation, we must have an e-mental health framework. And then finally, we focused a lot on the challenges and barriers in this study, but we also heard quite a bit about opportunities in our research. So I just wanted to highlight a couple of them as we go into the recommendations. So one service provider, and we heard this across the data set, indicated that despite the challenges and barriers to providing equitable digital mental health, it can also provide an opportunity to provide safe and accessible care to some populations. So this service provider is from Chile and says, in my case with transgender people and in our service, this pandemic has been an opportunity too, because in Chile, the resources of the mental health care with this kind of population is in few places in Chile, with very difficult to find safe places for mental health care. So the psychological attention online has been an opportunity for that at the same time as the risk. And there was also the results also showed that people really think of this shift under the pandemic to digital mental health as an opportunity to strengthen mental health systems. And so this policymaker says, I'd look at this as an opportunity. Even pre-COVID, access to mental health we know around the world is a major problem. I would look at this as an opportunity that beyond the COVID-19 pandemic, how can digital mental health and telehealth care complement the already existing health systems that are rolling out mental health services in different settings and countries? So they really see this as an opportunity to move forward, to integrate digital mental health into stronger mental health systems. So I just want to identify some recommendations based on these findings, and this is obviously a very high level summary, and we are about to submit the findings of this study for publication, so please stay tuned, which provides a much more nuanced and detailed overview of both the results and the recommendations. But I'll just summarize some of the findings and recommendations before concluding. So we identified a number of challenges, and the first is really that one size does not fit all in digital mental health. I don't think one size fits all in any case, but especially in this case in digital mental health. And there's a real gap in accessibility and appropriateness for many populations who need mental health support. So a recommendation at a high level would be to advance research and policy, and also to invest in the development of digital mental health supports that ensure access for diverse groups, including people with serious mental illnesses, disabilities, low digital literacy, safety concerns, and other access needs, as we described in the results. And these are described in much more detail in the paper. We also know that, that people from diverse populations often experience increased negative mental health risk during the pandemic and experience higher barriers to access, but they're also very underrepresented in digital mental health design, research, and policy development. So a recommendation would be to integrate equity considerations into digital mental health research, monitoring, and evaluation, and also, very importantly, to meaningfully engage diverse people with lived experience in all facets of digital mental health research, design, development, and policy processes. Another challenge identified was the lack of digital infrastructure. So for example, lack of internet connections in rural and remote areas, as well as device access, including among people with low socioeconomic status. So there's a need to increase public and private sector investment in digital infrastructure and access, including via public-private partnerships. We also heard from the data that there's a need for improved digital mental health governance and policy. And this has a lot of implications, including the need to integrate digital mental health training into mental health provider curricula, as well as curricula for other health and social service providers. Develop, implement, and disseminate clear and transparent data privacy and security policies to help address some of those trust issues and confusion around confidentiality and implementation. And extend payment structures to make sure that digital mental health services are covered by, in our case in Canada, it would be by provincial health services plans, but in other jurisdictions to make sure that these are covered by health insurance or public healthcare plans. The lack of trust and confidence in digital mental health came through strongly among service users, providers, and also policymakers. So there's really a need to promote transparent, targeted, and accessible communication about digital mental health effectiveness, risks, and availability that are targeted towards specific populations in language that's very easy to understand, not using jargon, but to really meet people where they're at in terms of their concerns and to raise awareness. The lack of standards for digital mental health dissemination, health system integration, and delivery was also a key finding. And as our study participants recommended, there's a need to create and implement policies, standards, and frameworks with that also have explicit equity considerations. And finally, it's impossible to overlook the fact that digital mental health equity interacts with structural and systemic challenges, for example, mental health system capacity challenges, social and digital determinants of health. So again, we really see this as an opportunity to invest in comprehensive equity-oriented policies that promote equitable digital mental health within strong mental health systems. And there's a need to collaborate across sectors to promote progress on the determinants of health, including social, structural, and digital determinants. And so for my final slide, I really want to pass it over to the participants as an invitation for reflection and discussion, especially in the context of the network that's here today. Whether you're part of the Digital Hub network or not, there's obvious interest in promoting mental health equity and specifically digital mental health equity. So I'd like to invite reflection on a couple of questions. The first being, how can the APEC Digital Hub Network build on this work and promote equitable access to digital mental health in the future? And specifically, how can we, under the 2021 to 2030 roadmap, advance cross-regional efforts to promote digital mental health equity? And so I'll stop there and open it up for questions. I think we have about Rosie, how are we doing with time?
We have 10 minutes per question.
10 minutes, great.
Yes. Yes, and I'll just remind people to please put questions in either the chat or the Q&A part of our Zoom platform here. Wonderful presentation of a very large set of data, Jill. And so I guess, maybe I could start off and ask about, in terms of equity-seeking groups, we also have, different levels. And I think age is particularly one that is talked about for digital interventions. The differences between older people like me and their familiarity with technology, and then younger people who, have grown up with social media and digital technology. And so I would think that there needs to be some, clear differences in terms of, things like apps that might be available for those different groups, even within, equity-seeking groups.
Yeah, absolutely. And I think you're a very tech savvy person in your age group, Ray. But I agree. Age, in terms of, there was a number of concerns around age and equity-seeking groups that came through, including seniors who may not be as comfortable accessing care, even using telehealth, let alone using apps or web-based programs, and then youth who may be a lot more capable and interested in accessing digital mental health, but often in the context of the pandemic wasn't necessarily always a safe and secure option for them. So I think, again, this goes back to sort of the one size does not fit all, and there really needs to be efforts to ensure that that all modalities are leveraged to be accessible to the age groups that need them. There are some good examples of I think a project in the US, I can't recall the name, that actually invested in sort of a training sessions for seniors to support them to access online care during the pandemic, and to kind of give them crash courses on using app-based care. So I think support services that go along with some of these interventions for people with lower digital literacy or lower comfort levels using apps and things like that are also really important.
Great. There's a question here, Jill, from Lucida Lazo. If you can see that, maybe you could speak to that. Maybe repeat the question.
I'm just going to read the question so everyone so everyone's aware. So Lucita says, maybe we can organize exchanges of experiences in APEC member countries in promoting equity. The Philippines has one such experiment in the Panay Island, extending services to ethnic groups known as Atipan. This was supported by ADB. Thanks very much, Lucita, for the comment and suggestion. I think absolutely yes. A big mandate of the Digital Hub is really to kind of facilitate this cross-regional learning, and we're always looking for collaboration with representatives in the APEC economies. So I think knowledge sharing, sharing best practices, and collaboration around these ideas is definitely an excellent next step.
What kind of formats do you think that kind of knowledge exchange could take? Because I know that this is one of the trickiest things, right? Trying to find out what kinds of outstanding programs that there are in other places, and trying not to reinvent the wheel. I think that's one of the things we're hoping to have input in during forums like this, in terms of what people would like to see in terms of formats of that information and knowledge exchange.
Yeah, I think if folks who are in the webinar have ideas about that, we'd love to hear from you. Another limitation of this work and some of these, we have such capacity using Zoom and these online mechanisms to collaborate, but it does, exclude people that are excluded from digital mental health care. So I think we also have to acknowledge that efforts in the future have to sort of go beyond doing things online, and to be able to really hear the voices of people that may struggle with digital mental health access. But Lupita, I don't want to put you on the spot, but if you have ideas about how that kind of knowledge sharing could take place, or if others do, we'd love to hear it in the chat or the Q&A.
Okay, well, if we don't have any further questions, let's use the time for our next series of presenters. So I'm going to pass it on now to Dr. Arun Ravindran from the University of Toronto, who will moderate the first of our lightning talks. Dr. Ravindran?
Thank you, Ray, and good evening or good morning, depending on where you are. It's nice to be with an international group at this time. So let me start off by introducing our first, before that, some of the housekeeping rules that Jill has already spoken. So the presentations are going to be 7 minutes, and hopefully 2 to 3 minutes for questions for each presenter. Our first presenter is Dr. Julie Caballero, who is currently the Director of Mental Health, Ministry of Health in Peru, and a professor at the Peruana Gaetano Heredia University in Peru. Her expertise is in the provision of health services, and she's going to talk to us today about promoting mental health care in Peru. Dr. Caballero, the floor is yours.
Thank you very much. I will share my presentation.
And one quick comment, I'll give you a warning 1 minute before your time is up.
Okay, thank you. Okay, here. So today I'm going to talk about promoting community-based mental health services in Peru. Our country has around 33 million inhabitants, spreading over a vast territory with 2 mountain chains crossing the region with complicated geographical access, especially for Lima, the capital city, which holds 30% of the population and centralizes the majority of public services. At the beginning of the current millennium, especially after political violence and terrorism, there was a greater necessity to receive mental health care in Peru, especially for the population affected by political violence and also violence against children, adolescents, and women. This generated an increased awareness of mental health problems and a greater demand for the government for policies regarding mental health services. In this context, in 2012, the General Health Law was modified and established that the Peruvian state holds responsibility of ensuring the exercise of rights to people with mental health conditions. Furthermore, it set the community mental health model as the standard of care, shifting the attention towards the mentally ill patient to a citizen in need of mental health care. This new model works with an interdisciplinary approach to healthcare networks in a defined territory and promotes social participation and mobilization for mental health care in the community. In 2019, the mental health law was enacted. This law further empowered the modifications made by the Health General Law and broadened the exercise of rights for people with mental health conditions. In addition, it established the National Council for Mental Health, which incorporated several sectors of the government to focus interventions on the social determinants of mental health. Moreover, this mental health law gave us the opportunity to implement new facilities and new services to address people with mental health problems, including community mental health centers, but also services with psychologists in primary care, also mental health hospitalization units in general hospital, shelter homes, among others. In the last 7 years, our country has had the possibility to implement and decentralize a variety of community mental health services through a participatory process involving different levels of government across our 24 regions nationwide. This implementation process includes approximately 3,400 psychologists in more than 1,400 primary care centers, 249 community mental health centers, also 54 brief hospitalization units in general hospital, 87 shelter homes for people with long-term and severe mental health conditions with little or no family protection. Simultaneously, the Ministry of Health has increased the list of essential psychotropic drugs delivered free of charge from 1 to 15, and also has strengthened the capacities of thousands of health workers to carry out diverse mental health activities. To promote the proper functioning of these community mental health services, we have also approved many regulatory framework that guides the actions of the decision makers, the managers, but also of the healthcare personnel and other workers that provide care.
1 minute more.
These efforts wouldn't have been possible without an increase in the mental health budget. A very important milestone was the creation of a result based only for mental health activities. And it is very important for us to ensure that this increase in the financial resources are also directed to the country's regions and not only for Lima, the capital city. Over the 9 years, the number of cases treated for mental health problems has increased, and consequently, also the coverage of care in this community mental health service. Finally, would like to say that experience has taught us some strategies for mental health reform, like spreading tangible, territorialized, and specialized mental health services with a community perspective, boosting mental health care in primary care, strengthening community networks in each territory. But still, we have challenges, like, for example, improving access to mental health services for geographically dispersed population, but also how to insert the digital clinical record software and technologies in order to improve the quality of the health of the care that we provide. And we hope that in a short time, we can share with you the results of these new challenges that we are working on. Thank you very much.
Thank you, Dr. Caballero. We have 2 to 3 minutes for questions. No questions? Are there any other comments you want to make, Dr. Caballero? You have a couple of minutes if you want to emphasize anything that you have already spoken about, but felt you could add something.
Yes, I would like to add that this has been possible also with the support of the academia, with the support of the social and community resources, organized families of persons with mental health problems, and with congressmen, and with different key actors.
Wonderful. Thank you for your lovely presentation, and we are frozen a bit, I think. Okay, that's better. Thank you. On behalf of the audience and the Digital Hub, I'd like to thank you for your outstanding presentation.
Thank you very much.
Thank you. Our next presenter is Dr. Tae-Yeon Hwang, who has had a distinguished career as a psychiatrist in Korea, having obtained his MD and PhD degrees in Korea in psychiatry, and also trained in Columbia and at the University of Melbourne in Australia. He had a distinguished career as the director of WHO Collaborating Center for Psychosocial Rehab and Community Mental Health, and as director of the Department of Mental Health Services and Planning at the National Center for Mental Health in Seoul. In 2021, he became the president of the Korea Foundation for Suicide Prevention, and in this capacity has been working with the Ministry of Health and Welfare in developing policy, prevention, intervention, etc., on a very topical issue of youth suicide, and he's going to talk about the perspectives from Southeast Asia. Dr. Hwang, the floor is yours.
Thank you very much, Chairman, for your nice introduction of me. So it's my great pleasure to share the suicide prevention issue. It's a very important social issue in Asian countries. So in these slides, you can see the suicide rate among OECD countries, teenagers, and then the 20s. Suicide rates are very high among New Zealand, Australia, Lithuania, Finland, and Korea. And WHO fact sheet tells us that over 800,000 people die by suicide every year. And then suicide is the second leading cause of death among young people from 15 to 29. But suicide is preventable, and then key is the comprehensive, the multi-sectoral approach. So this is the data from Korea, and adolescent suicide of Korea is growing up from 2017, beforehand, after the COVID-19. Now in Korea, we are seriously worrying about the young people's suicide prevention. especially women from teenagers through 30s show high suicide attempt arrived at the emergency room right now. If we look into the cause of suicide, men and women are different in Korea. Data about men, young people are different from middle age and old ages. And the common cause of suicide among the young people is mental illness. But in women, all ages, main cause of suicide is a mental health issue. In Philippines, youth having suicidal thought are increasing now, especially among the female group. And in Malaysia, suicidal thoughts and the attempts are common among adolescents, especially from the girls more than the boys. Also, it is increasing through decades. Even though Singapore's overall suicide rate is decreasing, but the number of suicide among youth is increasing in the last 5 years. And Japan also shows increasing number of suicide among adolescents, and the media reported that this is the Japanese society's real crisis. Main reasons for committing suicide among Japanese the students are familial discord, and then worry about the future, and then reprimand by the parents, and then the struggling with the parents and child, and the mental disorders. In Korea, suicide method of young people shows the jumping, hanging, and gas inhalations are very common. If we look at the suicide method of young people from other countries, you can see the diverse causes, such as the jumping is the main cause from Hong Kong, and the poison by gas is common in Japan. And WHO suggests key risk factors for suicide and strategy over the universal, selective, and indicated prevention according to the risk factor in society, community, and the relationship between citizens. WHO showed that the mental health and well-being of young people has affected by COVID-19, especially by the duration of school closure and lockdown. After school closing over 2 weeks, the 96% of students reported negative emotion and feelings. For the young people, influences of social media and OTT are enormous, especially in Korea. There are many suicide-provoking contents and recruiting accompanying suicide persons. So in Korea, we are discussing how to block this hazardous information and call for the voluntary regulation among the many portal sites. And WHO Western Pacific Regional Office suggested the surveillance system for the suicidal ideation, self-harm, and suicide attempt through the national database in ambulance, emergency room, and then the regional registration system. And also you can see the foster life skills of young people as one of the key effective evidence-based interventions for suicide prevention. This is very important for the school mental health and suicide prevention. In Singapore, community-based mental health team are preventing suicide among the young people, and the REACH team is working with the school counselor, and the chat team is support the young people to recognize their mental illness. In Japan, the government provide the basic package and the priority packages for the local government and services for children and the youth is the highest priorities for local communities. For the practical suicide prevention, we must develop the program for the specialized for different age groups and then population. A school mental health program is provided by school nurses are very important. The local government, the colleges, and the military armies developed their own suicide prevention centers and programs in Korea.
1 minute more.
Yep. To identify high-risk group of suicide, developing social network with the Social Security Services Center is very important. And child and the human rights violation can be precipitating factors for suicide attempt that the child abuse, the prevention centers and then human rights advocacy centers are linked with the local suicide prevention centers in Korea. So these kinds of efforts are very important to reduce the suicide rate of the teenagers in Asian countries and all over the world. Thank you very much for your attention.
Thank you, Dr. Hwang. And we have time for couple of questions, 2 to 3 minutes. Jill, are we having some hitch about people being able to ask questions on the Q&A?
No, I think the attendees can ask their questions in the Q&A, and then if panelists have questions, because we're not able to type into the Q&A, I suggest turning off putting yourself off mute and asking directly.
Right.
Thanks, everyone. It's Andy Greenshaw. Hi, Dr. Hwang. Nice to see you. I have a question about the approach. You know, it is in terms of communicating with young people in schools and in the community, digital access is much easier and less expensive than access through community nurses and community clinic kind of approaches. Is there any special funding or any special programs in place in your area to try and promote digital access through apps or through some kind of chat system, which is designed to inform young people particularly about alternatives to suicide and CBT, that kind of approach?
Thank you for your questions. Actually, we developed the hotline counseling services in Korea, but for the young people, the chat, the counseling system is more frequently used by teenagers as 20s. So Ministry of Health and Welfare and Ministry of Education developed the chat, the counseling system for the students and then young people. So it's a very useful for the teenagers to assess. And then your questions regarding the CBT, many community mental health centers provide the CBT for the very severely depressed the patient in the community. So the digital, the mental health care is more popular right now in Korea.
Yeah, thank you so much. I think in relation to one of the comments that a previous speaker made, there's a real opportunity coming out of this forum to compare resources and funding that have been put in place with successful examples like the ones that you have just described to us, Dr. Hwang. Thank you.
Thank you.
Thank you, Dr. Hwang. I think your outstanding work is going to contribute a great deal in terms of dealing with this terrible issue of youth suicide and could easily be modeled into most of the Asia-Pacific regions. Thank you.
Thank you.
I think our third presentation is going to be by video. and it's by Miss Enoch Li, but unfortunately she's not able to attend in person. So we have her on video. She's widely recognized as pioneering workplace mental health issues in China through her award-winning organization and spearheading consulting and psychosocial education services in Asia, China, and Asia Pacific regions. She integrates the organizational development and group psychodynamic approaches, trying to build bridges between sectors to mobilize system shifts, such as changing the workplace environment that damages and burn people out. So we will listen to Ms. Li now.
While we're waiting, perhaps there were some questions for Dr. Caballero that got missed from some of the panelists. And one of the questions was whether there was, what was the funding like for mental health compared to other, other medical conditions in the program? And is there any dedicated funding for digital virtual mental health within the portfolio?
Thank you for those very interesting questions. The funding represents 10 years ago, the funding was 176 million soles, which represented 1.6 of the general health budget. In 2023, we have approximately 600 million soles, which is like 3 times the budget of 10 years ago, which represents 2.6 approximately of the general health budget. So we have increased, but it's still less than what it represents comparing with the countries of the South American region. And we have exclusive amount of money to digital health, but the first step is to reduce the gap of what we need to implement the digital health. For example, computers, webcams, headphones, and other issues in order to implement the mental health component of the clinical record, but also to implement and insert other technologies to improve mental health, including digital mental health.
It's any other questions for Dr. Caballero or for Dr. Hwang?
Maybe I have a question. Oh, sorry. Go ahead.
No, I'm going to try sharing the video, Enoch's video from my screen. So
okay.
Let's all hope that this works.
Hello, everyone. My name is Enoch Li. I'm the founder and managing director of Bearapy. We are an organizational consulting company based here in Beijing, and we provide mental health education and awareness to organizations in hope to destigmatize the topic for them. Our goal is so that employee well-being is embedded in workplace culture sustainably, and that we don't overemphasize the individual as if they are the only issue. I'd like to say thank you to APEC Online Digital Hub for inviting me to share some perspectives from the ground, and I look forward to participating in this discussion. Now, usually I think when we think about equity and access, a lot of immediate thoughts go to supply of resources. When I think about equity and access in the context of workplaces, 2 words come to my mind. The first one is bias, and the second, leadership. Let me illustrate with some examples that our team have encountered here on the ground working with organizations. The first example is a conversation we had with a HR director about possibly promoting workplace mental health education for the employees. And we asked her, well, what is the current status in her organization? Where does she think the needs are? Her response was, I don't think there's any need. Everybody looks really happy. We're fine. We already have an employee assistance program in place and no one uses it anyways. So we don't need to spend more time and energy on education or workshops. Now, employee assistance programs are quite popular for organizations where they subscribe to a service by a service provider, and employees have access to counselors through the phone or through the apps or through the websites, and to seek help when they need, and especially professional support. Now, to think about this example, the idea that because the utilization rate of employee assistance program is low and therefore we don't need more mental health education, for me feels a bit like the wrong question to ask. What we really need to be asking is, well, why is the utilization low? And perhaps if we flip it and think about it as because there isn't enough mental health education and awareness amongst employees, therefore the utilization is low. So what we can see is actually the perspectives and bias of the decision maker is actually hindering the access to resources that are readily available for employees to use, to learn, and to build their knowledge. We're also not thinking about some of the issues in companies where perhaps it's not really about the education or the knowledge level, but about the sense of trust to the company. At this point, I'd like to share some findings that our company has done over the few years. This is a position paper that we are about to publish in about a month or so in conjunction with World Mental Health Day. This paper was built through qualitative research, interviewing 20+ employees, and also quantitative research, surveying about 200 employees based here in China. We also built in some of our examples and work with companies over the years to think about and to drive the conversation of, well, actually, what is the misalignment between what senior executives think about workplace mental health and what employees really need? I'd like to highlight a thought about the employee assistance programs, that it really, utilization perhaps isn't because employees don't know about it. It's perhaps because they don't feel supported by it, or they don't know that they have access to it. And more importantly, they don't feel they can trust the organization. 59% of the people we surveyed do not feel supported by the organization. They're also worried about issues of privacy. They're worried that the company will be monitoring them as they call these hotlines. They're also worried about the repercussions on their career if they do use these hotlines. So that's the first thought on bias that hinders access to resources. The second thought is leadership. And what I mean by that is we encounter so many decisions maker, HR directors who tell us, we really want to do something for employees, but we have no budget. If I push a bit further, I'm not sure that it's really because there is no budget, especially if the company is recording profits. What they're really saying is, we don't want to allocate this budget, or how can we allocate this budget? And employee well-being may not be the priority over business. Now, our argument has always been that employee well-being is a business asset, that it really deserves a place on the agenda as a business and strategy item to be discussed at the very top level. So it really relies on leadership and decision makers to think about this, so that it's something that's sustainable, long-term planned with initiatives over a few years, with benchmarking and impact measurement, and not just a feel-good factor. And I've written about this on Insert Knowledge a few years ago of how can we look at employee well-being as a business asset. We also need to think about asking these questions by those who govern, such as boards of directors, asking the executive directors, what are we doing for employees? How are we measuring it? How do we quantify presenteeism and absenteeism in the workplace? How are we measuring the impact of education and awareness initiatives that we do? And these initiatives also need to be suitable to the different demographics, not just age or gender, but really thinking about those who have mental health lived conditions. How can we engender a workplace that is conducive for those who live with mental health conditions, the type of workers, the different education background, the intersectionality of mental health and other diversity and inclusion issues. One of the things that we really advise companies to do is to think about using lived experience of their leaders and really to educate and cultivate that culture from top down as well as bottom up. As you can see, one of the respondents we quote in our position paper says, when leaders of all levels share their personal stories, it really helps to role model vulnerability as a strength, and it helps to destigmatize. But I do want to highlight some things that I haven't talked about. The experience that I've gathered and our team works with are usually organizations who are corporates, who are thinking about these topics progressively and also have the intention to try to change. There are many other different workplaces, such as that of non-governmental organizations. There's freelancers in the gig economy. There are entrepreneurs, there are social entrepreneurs. And these workplaces, they are really the ones who may not have the budget to implement something for their own employees. I remember a few years ago when I spoke to a venture capitalist friend of mine, and he said, well, if one of their CEOs that they have invested in had depression or burnout, they would just change the CEO. Now, times have really changed, and I know that in the investment community, we're really starting to think more about how can we keep up the mental health of these entrepreneurs and the organizations that we invest in. And I really call on funders and investors to think about allocating a budget for the mental health of the employees who work in the organizations that they have invested in, because then this is a long-term sustainable growth and development of people instead of a one-off, let's fix the problem perspective. And if done well, workplaces can really be a strong platform to make access much more equitable to thousands and thousands of employees who work for companies across the region and even globally. Thank you very much for thinking through this topic with me. I know I'm not speaking on real time, so I've left here my contact details. Please feel free to get in touch with me on LinkedIn and also our company page. We will be publishing the position paper in a month, and we look forward to your reflections and thoughts. Thank you.
Great. So Jill, you are going to take over the
Yes, thank
for
you.
the next session. Yeah.
Thank you, Arun, and thank you very much to Dr. Hwang and Dr. Caballero for your excellent talks and for all of the great questions. Enoch is in the UK at the moment, so I think it's 2 a.m. there, which is why she provided her pre-recorded talk. But again, if anyone wants to connect with her and has any questions, she gave her information, or you can reach out to us to connect with her. So we're going to move on to our second lightning talk panel now, which will be moderated by Dr. Erin Mahalik. So Erin, I'm going to pass the floor over to you, and welcome to our speakers for the next panel.
Thank you, Jill. And wasn't that just a fantastic, provocative presentation by Enoch Li? I really enjoyed that, particularly the idea of elevating vulnerability as a strength in leadership models. So kudos on that presentation. It's a real privilege for me, of course, to be able to introduce our speakers for our second set of lightning talks. Of course, 7 minutes goes quickly. So Dr. Ito, I'll give you a 1-minute heads up when you're at the 6-minute mark. And let's, as a group, take questions for all of the panelists at the end, because it gives us a bit more time, I think, to think about the questions. And just a reminder, you can drop those into the question and answer box or into the chat, and we'll moderate them at the end of the session together. But over to presenting the biography of our first speaker. Dr. Hirito Ito is a professor in the Department of Health Policy and Management at Tohoku Medical and Pharmaceutical University. He's a very experienced government researcher previously, with over 2 decades of work serving on many numerous government panels in Japan. He's published well over 100 papers in some very esteemed journals: British Journal of Psychiatry, Harvard Review of Psychiatry, Lancet Psychiatry. And he's been a member of the Community Mental Health Committee of the World Psychiatric Association in 2010, and a member of the Guideline Development Group of the WHO Guidelines on Mental Health in 2022. Dr. Ito, it's wonderful to see you again, and I'm very excited to hear you present on deinstitutionalization and regional economic growth. Over to you.
Thank you, Erin. I'm very happy to talk with this comment, and thank you all for giving me this opportunity to talk about the Japanese story. Deinstitutionalization refers to a movement that advocate the transfer of people with mental disorder from care in institutions back to families or community-based homes, thereby promoting community mental health. However, there are some critics of deinstitutionalization. For example, the main driving force behind it is cutting costs. It increased homelessness of people without jobs. Moreover, deinstitutionalized patients are not happy. We believe that deinstitutionalization is not necessarily dependent on such critics. So the purpose of this presentation is to illustrate a model community case in Japan that proactively promotes regional economic growth through deinstitutionalization. The model community is the mental health services in Ainan City, Ehime Prefecture, with an approximate population of 20,000 people. Ainan City had a private psychiatric hospital. The hospital was closed down in 2015, led by the director of the hospital, Dr. Nagano, who is a co-presenter in my talk. Dr. Nagano has been extremely kind in disclosing the trends in the number of patients and staff, as well as the financial aspects of the organization before and after the closure. This graph shows the number of inpatients in black and the number of patient work days in red. This graph shows chronological trends in the number of staff members. You will notice that the total number of staff members remains unchanged. Importantly, the staff at the other social services gradually increased until the hospital closure and drastically increased after the closure. This means that deinstitutionalization is not only a matter for the inpatient, but also for the staff. Professional recurrent education is important. This graph shows the financial changes in the private organization. Surprisingly, the total revenue had been increasing because of income from outpatient services, such as outreach services and daycare services. Dr. Nagano, the director of this private organization, started lunch delivery services for the people in the community. In addition, he started mushroom cultivation, which received an award from the Ministry of Agriculture, Forestry, and Fisheries. I am talking about the closure of the hospital and its impact of the organization, the upper part of the red line of the slide. Dr. Alain Francis, a psychiatrist in the United States, visited the Ainan City and described the activity as successful inclusion of the mentally ill as full-fledged citizens. The lower part of the red line indicates a more positive impact on regional economic growth. Because it is rather complex, I will briefly introduce its essence. A country's gross domestic product, GDP, is divided into three aspects: the production of new value as money, allocation of the money, and consumption and investment of the money. Similar to the national GDP framework, each region has a gross regional product, GRP. Our research group has made it possible to calculate the GRP of each region from a healthcare perspective. After the hospital's closure in 2015, the GRP of Ainan City improved in 2018. We believe that this is partly due to an increase in social services and new jobs. In Ainan City, patients staffed hotel, spa, restaurant, catering services, convenience stores, landscape companies, nurseries, fish farms, cemeteries, campsites, and extensive groves of profitable avocado and orange trees.
1 minute.
A landmark result was the success of cultivated avocado for the first time in Japan by a team in Ainan City. This avocado is the highest brand in Japan, and the famous fruit shop in Ginza, Tokyo, is selling 1,000 yen each, 10 times more expensive than other important avocado. People in the left picture are leader in landmarket company in Ainan City. Dr. Alan Francis published on Dr. Nagano and the Ainan City activity in Psychiatric Times. It is better both emotionally and economically for the patient to earn a paper than to receive a disability check. In conclusion, Dr. Nagano and Ainan City activity not only end stigma, but also add value to the community where they live. This is the final slide. The organization operates a Japanese-style onsen hotel with hot springs. Please visit Ainan City and enjoy countryside life with onsen. Thank you.
Immaculate timing, Dr. Ito. Well done. And just a fantastic presentation. Wasn't that a wonderful case example of how we look at the ecosystem of care models and the bigger picture of that? I so enjoyed that presentation, and we'll look forward to questions at the end. Thank you. Dr. Sean Kidd, are you ready to go? It looks like it.
I'm ready to go, and I feel so energized by a positive story about deinstitutionalization. That was just great.
Oh, it's wonderful to be able to introduce you. I still have the image of the avocado in my head, but moving forward, you're a senior scientist at the Center for Addiction and Mental Health, an associate professor at the University of Toronto's Department of Psychiatry. Your research includes numerous trials of cognitive and critical time interventions for schizophrenia spectrum populations, looking at things like housing stabilization interventions for homeless youth, digital health interventions for folks with severe mental illness, and global mental health work in the area of climate change and homelessness, very top of mind for us all right now. Really looking forward to hearing you present on mental health equity in the climate crisis.
Great. Thanks so much for that kind introduction, Erin. And I'll just dive right in. I might stay in non-presentation mode just so I can see faces and things like that. But just diving in, I know I just have 7 minutes for a pretty big topic. I've listed a few sources of funding here, and I have no disclosures. And really, the work I'm presenting here represents the work of a global network doing work in climate change and health equity, as well as a group in Canada. So climate change, I'm sure, as a topic does not need very much introduction. I would really guide anyone who's interested in getting to some of the details with respect to health to the Lancet Countdown series. The next one, the 2023 one, should be out actually quite soon. But just very briefly, of course, we know that the climate crisis is leading to a complex array of challenges, including those direct related to storms and disasters, more secondary implications such as pollution and disease, and the whole cascade of problems that are caused related to food, water, energy insecurity, impacts on people able to get on with their daily lives, things like displacement, increases in violence, and really importantly, it has quite a range of different impacts depending on who's being impacted. And we see globally the greatest risks of illness and mortality amongst older adults, infants, children, and women. In terms of climate change and mental health, there's a lot out there and there's not much out there sort of at the same time. So the latest review that I've been able to find is 2020, and we were climbing well past 100 papers. And really the sorts of things that those papers are describing are really a broad range of implications of climate change on mental health. So everything from subclinical anxiety and an anxiety not tied at all to any particular climactic event, but you might have heard the term eco-anxiety, just a general sense of worry, concern, hopelessness, helplessness related to the climate change existing. And then, of course, people exposed to extreme weather events. You see challenges across the board in heat waves and droughts. You see suicide spiking, and as well, the sorts of secondary social challenges that tie in with mental health and addictions challenges, such as violence. As you see, calls to police, for example, related to domestic violence increase greatly when there's a heat wave. And then, of course, health disparity pieces kind of play out of that, with women, for example, being most exposed to violence in those circumstances. And then people with pre-existing mental health challenges. So people, so psychiatric populations in heat waves, for example, floods, so on, you see increases in psychiatric hospitalizations, illness, morbidity, and mortality with those populations. A topic that has had less attention is brain development and the impact on the brain. And there, we recently completed a review and seeing implications. And here's where health disparities or social disparities really kind of play out. For example, with heat, pregnant women who are exposed to heat, there's significant greater risk of hyperthermia and implications for maternal health, but also fetal development. And there's kind of a developmental cascade of challenges that you see amongst developing fetuses, infants, and children who are exposed to heat, who are exposed to disease associated with climate change, air pollution, quite a lot of evidence mounting there. And again, it's children, infants, and fetuses that are more exposed. And of course, more exposed people will tend to be impoverished in most parts of the world.
Sean, my apologies for interrupting, but
sure.
Would you mind going to the full screen on your PowerPoint just for
sure,
accessibility issues? I think it's a little bit of a struggle for some people to read the text size. Thanks.
Got it. Yeah.
Thank you.
And so I'm going to give an example that I think exemplifies these health inequities related to climate change and mental health as well. From the main focus of my own work, and that is looking at homeless populations or populations lacking adequate shelter globally. And it's a couple of pictures here some colleagues sent. So in the upper left is a slum outside of Nairobi. It's the largest slum in the world. And there they struggle a great deal with flooding for highly exposed populations, and the mortality rates for infants and children are extremely high, older adults as well. The lower right is Sao Paulo, Brazil, and people trying to use found materials to have some sort of protection against weather extremes. And what we found in the global work is for a population, a highly impoverished population, such as people lacking adequate shelter, the main themes that we see are climate-driven migration. So people who are in precarious circumstances, who lose their housing, whatever housing they might have, and then are trying to migrate often from rural to urban environments for the sake of subsistence and survival, and the vicious cycle of increasing challenge that those populations face, and then exposure. And I'll just give a couple of examples here related to exposure. Is if you look at a homeless population, heat, for example, is impacting people who have a range of pre-existing chronic illnesses, mental illnesses, and physical illnesses, malnourishment, all of the other challenges there. And then those moderators, you see that playing out in terms of illness, morbidity, and mortality. And so there's a range of factors that come into play to have quite bad outcomes for people who are more exposed. And heading in the direction of response,
and 1 minute.
Related.
1 minute,
sorry.
Sean. It's okay.
Oh, gotcha. Okay, home stretch. Heading in the direction of response, what we see is a lack of inclusion, whether it's adaptation mitigation plans and responses, disaster response plans, and we're really responding in a very after-the-fact manner with heating and cooling centers, giving out water bottles. And really our research is largely through associational kinds of studies, largely just describing anxiety, and we haven't really got into how to intervene. And what do we need? We need to look at whole system responses, of course, getting into the specifics of who needs what, when, and where. We need learning systems to get more prevention oriented, and really a fundamental message here is engaging lived expertise and community knowledge in terms of what's relevant locally. And as well, we need to bring a focus to wellness and not just illness. So there's quite a lot of discussion about building psychologically resilient communities to respond. And I know this conference has an emphasis on digital health. And so this is in a very nascent with respect to the climate crisis and mental health, but major implications of using known methods and technologies in areas of risk detection, education, and engagement, expanding reach of interventions, and including reducing the carbon footprint of care. And so I'll end with a picture, just emphasizing the need to stop chasing around horses after they've left the barn and becoming more preventative. All right, thanks very much.
Thank you. Oof, that's hard to do in 7 minutes, isn't it? Well done. What a challenge we're putting forward for our presenters today. And on to our final speaker for this lightning talk session, Dr. Beverly Azucena. Beverly, it is wonderful to see you again after some time. I'll move on with your introduction while you get yourself online and your slides up. Hello, Beverly.
Hi, Erin.
Hi. Hi. So you're a fellow, let me just move this over, sorry. A fellow of both the Philippine Psychiatric Association and the American Psychiatric Association, Chief of the Medical and Professional Staff at the National Center for Mental Health in the Philippines, and the resource person of the Philippine Council for Mental Health, as well as the chair of the Committee on Mental Health Information Systems in the center, where you play a really key role in positioning the center in the landscape of global collaboration for the development of efficient and equitable mental health systems. That's a fantastic biography. I'm really looking forward to your presentation, and we'll hand the floor over to you.
Yeah, thank you so much, Erin, for that kind introduction. Okay, to all attendees from the different member economies of APEC and from the different time zones, good morning, good afternoon, and good evening. Today, we would like to present the Philippine journey in unraveling the complex path in approaching a rational and effective mental health information system and transform the current dearth of mental health data to a robust mental health database. Early on in the Philippine Health Review of 2011, it was recognized that our health information system in general was fragmented, creating information gaps and necessitating strategies to scale up the system. It can be noted that the Department of Health had early attempts to address the need through the following initiatives. The Philippine Integrated Disease Surveillance and Response Project that sought to establish a disease surveillance system in 2007. The Philippine Information Network in 2008. The Integrated Chronic Non-Communicable Disease Registry System in 2013, which, however, did not include registry of mental health data. The Integrated Clinic Information System, which is a homegrown EMR of the Department of Health to support the functions of a clinic, especially in the local health units. And the Philippine e-Health Information System to support the universal health care. The state of our mental health information system closely reflects the larger picture of the Philippine Health Information System. While it was recognized that an integrated mental health information system was paramount to the implementation of the first Philippine Framework of Action for Mental Health in 2014, it likewise recognized the misalignment and disparity of our mental health data. In 2015, during the APEC Roundtable meeting for the implementation of APEC's roadmap for mental wellness in the region, the Philippines, in its strategic needs assessment, underscored the need for an effective mental health information system as a focus priority of our economy to contribute in the implementation of the roadmap. Some attempts to place a system by the National Center for Mental Health and by some private organizations reaped some pockets of success, but were unable to reach a unified national system and lacked a governance structure. The enactment of the Philippine Mental Health Law and the creation of the Philippine Council for Mental Health were pivotal to the inception of a governance structure for the information system through a committee. This paved the way to the systematic development of the Philippine Mental Health Information System, which was launched in January 2022 in pursuit of the mandate of the Philippine Mental Health Law that required National Center for Mental Health to develop the system. The architecture of the Mental Health Information System has been drawn up, and it is envisaged to consist of three systems, namely the Administrative Data System, which shall contain data pertaining to the performance indicators in the framework of implementation through the scorecards of the different members of the Philippine Council for Mental Health. This is to provide evidence on the progress of the strategic plan for the implementation of the Philippine Mental Health Law. The software and the dashboard have been developed, ready to be populated with actual data from the member agencies of the Philippine Council for Mental Health. With the new strategic plan for 2023 to 2028, new indicators of the three strategic thrusts, namely mental health literacy, suicide prevention, and mental health financing, will need to be integrated. The second system is the research portal, which is currently being developed. The situational evaluation has been completed, and the software blueprint and dashboard are now being designed. We envision the completion of its development by the end of the year 2023. This portal is envisaged to serve at least 5 use case scenarios. 1, the patient lookup for individual intervention. 2, the service user or lived life experience data to serve as primary data for studies to improve mental health care delivery. 3, research lookup to find out what studies have been done on a topic. 4, researcher lookup to find out who has done studies on specific mental health topics. And 5, the secondary analysis of data to be extracted from various studies. The third system is the patient data warehouse, which will contain primary data on service users' socio-demographic profile, diagnosis, medicines prescribed, treatment and care interventions, and outcome of interventions. To lay the ground for the system, a readiness survey of the 22 hospitals under the direct supervision of the Department of Health, which are required by law to provide mental health services, will soon be conducted. Subsequently, the survey will be done with the private hospitals and standalone mental health facilities. The design development of the system will be initiated in 2024. The National Center for Mental Health aspires to have the mental health information system populated with relevant data from the various agencies, especially the members of the Philippine Council for Mental Health, and to complete the required training of the focal points to ensure that appropriate data are entered into the system. We likewise
1 minute, Beverly.
that the Philippine Mental Health Information System be a fully digitalized system and be institutionalized as a permanent cornerstone of the Philippine Council for Mental Health for policymaking, with a dedicated unit replete with technical positions for its operations at the National Center for Mental Health, and ensured as a line item in the General Appropriations Act of the Philippine Government Annual Final Budget. Finally, it is our ardent belief that by having an integrated national mental health information system, mental health disparities can be reduced, culturally appropriate interventions can be advanced, and mental health equity will be able to gain ground. This slide is to present the theme of the Philippine Mental Health Information System. Thank you for listening.
Well done on timing for that as well. Wonderful to see you back on the line, Dr. Kidd and Dr. Ito. I'll invite you to put your camera on now and we can take questions from the audience. Congratulations to all our panelists for making it through that speedy but very impactful presentation time. We'll start with a question for Dr. Ito. In Annan City, just one private mental hospital was shut down, ? How about the other public mental hospital? Was the deinstitutionalization policy from the provincial government, I think is the question. And I can repeat that if you want.
Okay. Yes, from the government, yes. I would like to answer to you in brief as a research of health policy and management, with my personal understanding of deinstitutionalization. In the current Japanese mental health care system, we can realize both deinstitutionalization and regional economic growth. Ainan City, led by Dr. Nagano, is the example. We can, but we don't. It is not a matter of policy, system, or budget. It is a matter of mental health professional. And it is not specifically the matter of mental health. It is a matter of general health and medical professionals. And it is also the matter of national and local policy makers and the matter of people in the community. It means the mental health awareness. I hope this example help you understanding of the institutionalization and regional economic growth. Thank you.
Perfect answer. Thank you, Dr. Ito. I'll ask a couple with chair's privilege as we wait for other questions to come in. Dr. Kidd, you talked about some really interesting scoping reviews that are looking at the relationship between climate change and mental health. I'm wondering how much data is coming out now, looking specifically at rural, remote, agricultural communities, farming. We know that across the Asia-Pacific region that these are real priority communities.
Yeah, absolutely. I think it's quite cross-cutting in terms of the data that's out there. I think, of course, probably most of the data is coming out of more urban environments, but there's emerging data showing particular stressors for rural communities, as you say, qualitative and quantitative both. I think it tends to be, in my experience with governments, somewhat of an afterthought, as often is the case for rural contexts. But the pressures are there. They're really quite unique, both in terms of the implications, but then also the difficulty of mounting responses to those exposures, given the geographic challenges.
Thank you, Dr. Kidd. And it's probably also an issue of metrics as well. The Philippines and Dr. Azucena's group have really been spearheading, driving advancement around metrics of mental health outcomes, but part of that presumably is around really advancing, capturing rural and remote status more effectively. Yeah. I think in a lot of data, we don't even get that baseline demographic data 100% right all of the time.
Yeah, definitely. And I think where we really need to go next, and there's a lot of discourse about we can't do the 20 to 30 years from bench to bedside process given the urgency here, so is to rapidly move from describing distress and challenge, but to look at what opportunities are there for rural and remote communities to come together in climate associated action, because that seems to be the best buffer in terms of mental health for most, is people feeling activated, being able to do some tangible things and feel efficacious. That by far seems to be the most effective thing for the mental health of communities in the face of this threat.
Empowerment. Yeah. And one final question before we move to a break for Dr. Azucena. I was really interested in the portal. I'm just wondering how different types of stakeholders are encouraged to navigate through the portal. You talked about researchers, people with lived experience. How is that journey to different types of information or engagement supported for different types of stakeholders?
Yeah. Thank you for the question, Erin. It's actually one of the topics that we have been discussing with all the other stakeholders. But the advantage of the Philippines is that we have now the Council for Mental Health, and the members of the council are actually the agencies that actually work on the mental health system, and it encompasses all the stakeholders. And through the system, we envision actually that it will be very inclusive. The mental health system of the Philippines will be very inclusive because of this information system.
Thank you. And some so wonderful themes coming from this session and time together: empowerment of communities, tailoring of responses, and looking at ecosystems as a whole, and the power of supporting people with mental health challenges to flourish in that complex environment. Thank you. Over to you, Jill.
Thanks very much.
Thanks, Erin, for some wonderful moderation, and to Dr. Kidd, Dr. Ito, and Dr. Azucena for really fantastic presentations and doing so well under the time constraint. I think you've given us lots to think about, and really exciting work going on in all of your areas. So we're at the point in the agenda now where we've just finished the first half of the online forum. So we're going to take a 15-minute break and come back for the second of our mini plenaries, which I'm really excited about, which will be by Dr. Anil Thapliyal from the E-Mental Health International Collaboration. And Dr. Thapliyal will be talking about digital mental health, closing the equity gap. And then following that, we'll have our third lightning talk panel, followed by some reflections and wrap up. So I hope you stick with us. We're running about 5 minutes behind, but I don't want to rob people of their break time. So let's come back at 5 after the hour. I hope that's okay with you, Dr. Thapliyal and Dr. Greenshaw. So we'll be back in 15 minutes. Thanks everyone for your wonderful presentations so far. We'll see you soon. We're going to move right along with our excellent agenda with Dr. Anil Thapliyal, and I'm going to pass it over to Dr. Andy Greenshaw from the Digital Hub exec to moderate this session. So over to you, Andy and Anil.
Thank you very much, Jill. Well, it is always a pleasure to listen to Professor Thapliyal and to be in the same space. Known to many of us, Professor Neil Thapliyal is widely known for his long-standing commitment to create a tangible and responsive digital mental health ecosystem to ensure timely access to mental health support and treatment. Anil is the executive director of the eMental Health International Collaborative, that is a leading global think tank in the digital mental health domain. And through Anil's efforts, EMEC works closely with lots of leading global bodies such as UNICEF, the World Economic Forum, EMEC member countries, and of course the APEC Digital Hub for Mental Health. Anil believes that we must focus on the service user, their families and carers. If the digital mental health solutions do not work for them, they do not work at all. And in the EMEC webinars, Anil's ideas and priorities are well represented in terms of ideas like co-creation of solutions with all of those stakeholders. So without further ado, Anil, I will welcome you to talk to us about digital mental health, closing the equity gap. Over to you.
Thank you, Andy. Thank you for this opportunity to speak to all the audience at this online forum of APEC Digital Hub for Mental Health. I'm going to focus on closing the equity gap. And just to illustrate a point as to how communication has shifted right in front of our eyes in the last decade and a half, since 2005. We all have one of these devices in our pockets, and we know how we use them. But what is quite surprising from a survey conducted in the UK in 2017, and what it presents is with the data that the number one utilization of using the smartphone, which all of us carry, is number one is texting, then email, the Facebook, the camera, reading news, shopping online. And what is shocking is making a phone call from the phone has for the first time not made it to the top 10 activities. And we buy a phone, but making a phone call from that phone device has for the first time has not made it to the top 10 activities. Now, the point here is to illustrate is how communication has shifted right in front of our eyes and how consumers are communicating at large. But also looking at the digital mental health domain and what are the subcomponents within it as to what makes digital mental health. It's easy to talk about digital mental health as a one thing, but we are talking about seeking information for yourself, could be for the third party, could be your partner, could be your children. So a range of people go there, and it could be physicians looking for some information for the patient they're seeing. So there are a range of information that needs to be sought, and that needs to be valid, credible information. So what does that information, where do we go for that? Engagement, it could be during the waitlist times. There could be while I'm waiting to see somebody. In some countries, we know the waitlist times can be, running into many months, and unfortunately, in some countries, it could run into years as well. So engagement during the waitlist, in between sessions. So there is so much of work that is happening in the engagement space in digital mental health. The treatment interventions, they range from generally sort of a well population, and then looking at the mild to moderate end of the equation, then also looking at the acute people in inpatient services. So we're looking at the interventions ranging right across the spectrum of clinical care. Then also looking at the fourth dimension of the digital mental health is looking at social support. So what happens to the people who have, say, for example, there's a presentation of self-harm in the emergency department. So if just in case we have attended to the person, and if we do not provide any other support, if the person has been discharged from the ED and gone back to the same alcohol-infested environment, domestic violence, unemployment, and you name it, there are a range of other studies out there and which can safely predict, depending on the variety of factors, when the person will be back in the ED again. So what does a good support look like to prevent rehospitalization or delay rehospitalization? So these are all the various subcomponents of the digital mental health. So looking at the digital as an opportunity rather than as something, wow, it's a something which is happening as an innovation. Regardless of whether we are using it today or not, but 5 million people right now, at this point in time, 5 million people every single day are doing the digital health downloads and using these solutions anyway, whether we describe it or not. And we also know a range of other statistics as to 90% of the providers believe a strong digital health strategy is critical to improving outcomes, increasing productivity, and enhancing clinician satisfaction. So we have a range of also challenges which comes with the digital. And when we are talking about putting it into practice, so we're talking about communities of interest could be the workforce, the direct end workforce could be the physicians, and variety of shape and form, whether it be GPs or psychiatrists, psychologists. So the whole element of the hesitation sometimes can emanate from factors such as the lack of trust. So how do I know what does this app do? What does this solution do? How do I trust it? Whether it works, is going to provide the benefit, and where does these solutions fit at the right point in time, touch point in patients' care pathways? So the trust, awareness, do we even know about these things exist? Accessibility, how do we even go about accessing? And governance of these systems, digital systems, but also reimbursement modality, depending on which country we live in, what is the relationship with the insurance providers and the likes. We also know that there are more than 365,000 solutions to choose from. In 2021, only 20% of those met the quality thresholds. And this is only 2 years ago we were talking about. But in 2023, only 9% of those meet the quality thresholds. So the challenge for all the decision makers and the commissioners of care in our various countries we are coming from, the challenge is how to ensure that we are touching only the 9% of those solutions and ensuring the solutions that people access, digital mental health solutions people access in our country, respective countries, are the ones which are safe and effective and not the ones which are causing harm. And we also know that how mental health has shifted in terms of over the years, in terms of first wave being in 1960s, people with mental health conditions should be in the community. So looking at the whole aspect of how the paradigm shift was taking place. The second wave was looking at 1990s onwards, introduction of the notion of the recovery. It is not just important for people to be in communities, but be an integral part of the community. So that was the second wave. But we are right in the middle of third wave, which is looking at community involvement is essential. And mental health goes beyond a diagnosis and medical model alone. There are so many other social determinants we know about. So what does a community involvement look like as an integral part? So in terms of looking at what does a macro population mental health engagement could look like. So there are some facts here. So I'm just going to use these facts. I'm going to use the 21-22, the 2021-22. This is 12 months suicide, completed suicide stats from New Zealand. New Zealand's census defines them as suspected suicides, but there's 538 completed suicide in that in that 12-month period. So the completed suicide per week are 10.3 per week, and of those, 66% of those are men in New Zealand. So looking at these numbers, some people would say, hey, are women completing less of or attempting less self-harm? But we also know our statistics here tell us that women attempt 3 times more, but are less successful in completion. And these figures are also very similar to the ones in Australia. So completed suicide cases known to the healthcare system here are only 28% of those people are known to the formal healthcare system. So what happens to the 72% of the people? If we are talking about equity, so it's easy to provide more and more resourcing for the 28% because we know they are going to present at some point in time within the healthcare system, and it's better to provide the quality quality of support and care for those people. But what about the 72% who are never going to reach out to the support for any support because they don't see the debt, the stress they're carrying has got anything to do with mental health, or whatever other life challenges and stressors they are having in their life. If they do not equate that to mental health, they are not going to reach out. But also there are many other cultural elements to it. There are many other aspects of remote, rural, and of course, mental health literacy, stigma, discrimination. There are so many other factors. So there's a population which falls into 70%, which also needs the New Zealand police also in the last financial year. So that means we're talking about range of factors, range of stakeholders coming into what could have been operated further by handcuffing somebody and taking them to a prison cell for the night to cool off. There are many other approaches. In New Zealand, there is a solution, digital mental health solution, very famous and very widely used by Maori and Pacifica communities. It's called Auntie D. And the rationale behind Auntie D was when this survey was being done, who is the most important person in your life? And they said, well, everyone recommends we all run to our aunties to seek the solution, the wisdom, the intervention for what we are the trusted source in our life. So the name Auntie D, actually there's a Dorothy, she is actually a real person. So Auntie D, her name was just cause of the cultural elements of it. And it's amazing to see how widely also worldwide it's also regarded and described as wise practices. Happy to share what some of the sort of literature which backs as to how, as opposed to Eurocentric perspectives, how some of the wise practices and they're being interwoven into digital mental health, how effective and powerful that has been for those communities. So looking at the population mental health approaches, we also know from the healthy part of our communities, at-risk individuals and the people who have got the diagnosis. So we also know from a digital mental health point of view as to what are those treatment interventions or solutions which can keep people healthy. How do we mitigate the risk and provide early brief interventions, and also provide effective and efficient clinical care over and above the in-person care that is also being provided in our respective countries. So what does good implementation of a good population mental health approaches looks like? So I'm a big believer, and I think it's widely accepted as well, that lived experience has to be the front and center of the co-design, not only the co-design, but the development and implementation. So as it was said in the opening, if it does not work for the person with the lived experience or living experience, their families and the carers, then it does not work at all. But that is only one part of the 5 core pillars to get the activation or the implementation right. The other 4 pillars are looking at the strategy and policy. So what if it is not woven into the way we are commissioning the structures of care, the system of care? So what does a good digital mental health standards, policy, frameworks, accreditation, activation, what does it look like at a government level, whether it be the federal or regional level? What does a good look like? And so much of good work is happening around the world in that, and I'll focus a little bit on that shortly. The third one is looking at who says it works. So where is the evidence? We just touched on only 9% of the total available solutions out there only 9% of them are safe and effective. So onus is on us to make sure the programs and services that we touch, commission, and provide for the populations are the ones which are safe and effective. Workforce seems to be one of the area of my biggest passion, because I just think if the workforce does not know that these solutions are there and how to prescribe them, how to navigate their patients through to these amazing solutions, how are they going to prescribe them? So what does a good workforce development strategy look like? Because most of the physicians that I know of, they have always said their first port of call would be to prescribe a non-medicated treatment option. But they also, in the same breath, also say, but they do not know what the non-medicated treatment option looks like. So what does a good digital mental health workforce development strategy looks like? And workforce very broadly defined. But the fifth pillar of this equation is the role of the industry, whether it be the creative agencies like Saatchi and Saatchi, Colenso BBDO, whether it be the Amazon Web Services, whether it be the Vodafone, you name the entire ecosystem, data aggregation agencies. And so unless and until we see all of these 5 core pillars in equal weighting of 20% each, and so the only way to create symphony is to let each maestro play their own instrument. Otherwise, it ain't going to work. So just focus a little bit on that later on as well. But just to give you some snapshot preview of what is happening in the strategy and policy landscape, Australia came up with their e-mental health strategy in 2012. And then they developed 2019 digital mental health standards. Federal Canada in 2014 published this Mental Health Commission of Canada e-mental health briefing paper. In 2022, Canada has published e-mental health accreditation framework, which is amazing, awesome piece of work. Ireland is developing a national digital mental health plan right now, which will be published in 2024 Congress in Ottawa, Canada. And New Zealand in 2019 published an e-mental health framework. And also right now, New Zealand in 2023 is right in the middle of developing a national digital mental health roadmap. US has published Substance Abuse and Mental Health Services Administration, which is SAMHSA, the peak body in US. They published an advisory on digital therapeutics for management and treatment in behavioral health. In UK, they do not have a nationwide policy framework, but they do have London-specific digital mental health strategy that is being led by Dr. Shahz Mehboob in London. Of course, under the NHS England we are talking about. So we also have in Canada, provincially, there are many provinces doing amazing work in Canada, one of them being the government of Newfoundland and Labrador, and they have developed a mental health and addiction strategy for the province. In Scotland, there's been a whole portfolio been created under the leadership of Chris Wright and for digital mental health. So there are many, many other publications that are there.
1 minute left, Anil, for your presentation.
So United Nations General Assembly has just on 26th of June this year has published mental health and psychosocial support. It's got a huge component on digital mental health. And I think it's quite important to note this is the first time UN has adopted a mental health and psychosocial support resolution. And it's been endorsed, unanimously endorsed by all 193 nations. At this point of time, I'll just probably just note the three things here, which is the last 6, 7, and 8 point. Activation programs to empower people to take ownership of their psychological health, embed services in the places where people live, work, play, and pray. So we can't just be focusing just on the primary care and secondary care, traditional support services where people go to seek support, broaden the set of interventions we use. So we have got a range of events coming up. One is coming up in Geneva on 9th and 10th, which is we're going to be expanding on all of this to develop a consensus on a draft set of key design principles for guidance on adolescents and youth, digital mental health. That is a program of work which is EMIC is doing in partnership with UNICEF, and also next year's Congress, where we're going to be looking at all of this, but with a view to digital building capacity. It's not a fringe innovation out there. It's digital building capacity, 24/7 mental health support for all. And how do we reduce that equity gap? Now, that's going to be in 19th and 20th of September in Ottawa, Canada. And I would strongly urge all the listeners to prioritize being there. Thank you so much.
Thank you very much, Anil. You covered a lot of ground there. Maybe I'll seed the Q&A with one question that we've discussed a number of times, and that is there are digital solutions out there. How do you persuade the stakeholders who are in control of the system, physicians and administrators, that we don't just need more bodies, we need to increase capacity by enabling digital, because there'll never be enough people to cover all the bases for all of this material?
I think we are past that stage now, Andy, where we have to convince people, but because everyone sees the need of digital now. So everyone has got a digital strategy in some shape and form happening in all of their countries. Now, but majority of the people do not know what does it mean in practice as to where do we start, what are those solutions. So every country ends up determining based on the need which is defined locally. So here in New Zealand, for example, the minister's priority were youth for a variety of reasons, because youth suicide rates were alarmingly high. And another one was 76% of the total completed suicide in New Zealand are men. So obviously, looking at the men became a second focus. So that's where the priority focus on digital mental health is also reflected in the way we have implemented the programs and solutions in New Zealand. But of course, then it gradually keeps expanding into other areas as well, into suicide prevention and many other areas. So I think I see it is more driven by the local drivers, which are political, strategic, and research-based. But I think embedding that into policy is the key driver here. So not doing it as a one-off, disparate sort of an initiative, but unless we embed it into the policy, have baseline funding allocation for it, so that otherwise it's just going to remain one-off innovation.
Thanks. We have a couple of questions. We'll start with Professor Ray Lam.
Terrific talk as usual, Anil. You know, excellent summary of the field. I guess one of the big issues, of course, is you know, how do we evaluate you know, apps, because you know, randomized controlled trials take too long, and you know, by the time we evaluate an app, it's changed. It's gotten better and bigger. So what are your thoughts in terms of how we should be looking at you know, evaluating apps to see whether they do actually what they say they do?
I think so. This is one area which I think your own country, Ray, has done really well, and I think Canada. I mean, so all countries are struggling with the same challenge. How do we do that expediently? So this commercially viable, and so they can governments can be more agile. So at this point in time, to my knowledge, there are close to more than 100 organizations around the world which provide those kind of services commercially, not from an academic institution. Some academic institutions, universities may also do that, but those solutions, as Ray, you said, they take a lot longer to go through. So what some of these commercially leaning solutions are amazing. All of them are good. To be honest, I can't fault one or the other. Some of them have got a lot more speed and agility as to how they fine-tune the models, so they can go through the evaluation. So, and the criteria they have created. So what has been evaluated today, for example, it needs to be re-evaluated 18 months from now again. So where do we find the machinery that makes it happen at a regular pace, where content may have changed, may have invalidated the original evaluation criteria? So Canada spent quite a big amount of sort of effort in this area, which is under the leadership of Mental Health Commission of Canada. And they worked with an organization called ORCA, which is an organization for review of these apps we're talking about. It's just based out of UK. NHS England uses them. 13 countries have deployed ORCA as a solution for their national needs. So I know Mental Health Commission of Canada worked very closely with ORCA, but it was not just about working closely, but adapting it for Canadian environment, but looking at the needs of the First Nations people, the whole aspects of how beautiful it has worked out and how amazing the solution looks like, which is no more what the English ORCA solution was. It's a very much adapted version. It's a very Canadian version, and it's I understand it's going to be rolled out very shortly. So it is happening, and there are various approaches, and Canada is taking the lead right now.
Thanks, Anil. We'll pass on probably the last question to Dr. Joe Murphy.
Thanks, Andy, and thanks, Anil, for a fantastic talk. My question was actually very close to Ray's question, so we don't have to spend a lot of time on it. I was just a bit disheartened to see the figure of 20% going down to 9% of digital mental health meeting the quality threshold. So I was just wondering how that measurement, you know, how that figure is measured. Is it using ORCA framework, or where does that how does that measurement take place?
Yes, that is a ORCA framework. So they have their own framework, and they have quality thresholds, and which is they use, and it's quite amazing how many of the apps never make it to the the criteria which you and I would feel comfortable with.
Thanks very much.
There's a comment from our colleague Lynn Brooks in Vancouver about certifications that you see in other industries like construction. And I think that ORCA and other organizations are moving towards that sort of top tier apps, and looking at different features based on what's a good fit, what's the population, and so on. I think the work of the Commission has been particularly good at refining what ORCA has done in the Canadian context, and they're feeding back to ORCA, so there's a kind of virtuous cycle of improvement between in that international collaboration. That's pretty impressive. It's super important to get that right? It is such an unregulated area in terms of people's choices. Ray, as you know, right? It's like the Wild West in the internet. So people do need guidance about what works. And you made the point that's, I think, really important about the role of industry. We don't really have time to talk about that, Anil, but somebody has to own app development and somebody has to take care of it and make it sustainable. And that means it has to be industry partnership. I don't think that's the domain of what government naturally does. I wonder what you think about that in closing.
Well, that's a same thing which I talked about in my, when I talked about the optimal activation implementation. The only way we can create symphony is to let each maestro play their own instrument. That's the only message I have, because industry is equal part in equal rating of 20% alongside evidence creation, alongside policy and strategy, alongside lived experience and workforce development.
Thank you. We're out of time. There was a comment in the chat about real world evaluations important. RCTs may not be the best approach to apps. There are so many things coming out of this area that will lead to sustained, interesting discussions going forward. So back to you, Jill. Thank you. And thank you very much, Anil, for a wonderful presentation as usual.
Thank you so much.
Yes, thanks again, Anil, for a great presentation, and thank you, Andy, for moderating. So we're moving on to our third and final lightning talk panel, which will be moderated by Dr. Chi-Eng. Chi, Chi there? I can't see.
Yes, I'm here.
Oh, okay, great. Sorry, I don't think I can see everyone on my screen.
Yeah,
Before I hand
he's
it
there.
over,
He's right next to you on my screen.
Oh, not on mine. Oh, there you are, Chi. Before I hand it over to Chi, I just want to remind anyone that's joining us since the break that please feel free to put your questions in the Q&A, and the moderator will be taking questions following the presentation. So please don't be shy to ask any questions you have. Over to you, Chi.
Thanks, Jill. Hello, everyone. We're going to kick off with the last lightning talk panel, number 3. So without further ado, I'd like to introduce our first speaker, who is Dr. Melissa Withers. She's the Associate Professor at Keck School of Medicine at the University of Southern California, where she also directs the Pedagogical Enrichment and Training, and she also directs the Global Health Program of the Association of Pacific Rim Universities, non-profit network of over 60 universities in the Asia Pacific. Her talk today will be on the gendered relationships between maternal depression and adolescent internalizing symptoms. Over to you, Melissa.
Hi, okay, thanks so much for the invitation. It's lovely to be here. Let me go ahead and share my slides. Hopefully you can see those. I just want to preface this by saying this work came out of the dissertation of a former student, Michelle Livings, who is now doing her postdoc at Princeton and who is also here available to speak. So she really did all the heavy lifting, and I'm just here to give the presentation today. So as was mentioned, we're speaking about the gendered relationship between maternal depression and adolescent internalizing symptoms. So a little bit of background. We know that from previous literature, several studies coming out of Brazil, Western Europe, and also among select populations in the United States have looked at this question. Does mother's depression differentially align with adolescent daughters and sons' internalizing symptoms? And so really, we know that adolescents whose mothers are depressed are themselves more likely to experience internalizing symptoms, meaning depressive and anxiety symptoms, but the results have been a bit mixed on the gendered aspect of this. So we explored this question again using a national sample of US mothers and their adolescent offspring. And so we did anticipate that adolescent girls may be more susceptible to internalizing symptoms than boys if their mothers are depressed. And this is in line with the evidence coming out of South Brazil, a longitudinal sample of rural American families, and a sample of American children whose mothers had a criminal justice involvement. So these data come from a really interesting study here in the United States, the Future of Families and Child Wellbeing Study, which is based on a stratified multi-stage sample of about close to 5,000 children born in large US cities, a population above 200,000 between 1998 and 2000. And births were to unmarried mothers were over sampled by a ratio of 3:1. And so this resulted in the inclusion of a large number of Black, Hispanic, and low-income families. Mothers were interviewed shortly after birth. Fathers were also interviewed, and then follow-up interviews were conducted when the children were about ages 1, 3, 5, 9, 15, and beginning in 2020 when they're 22 years old. So these, when weighted, the data are really representative of births in these large US cities. And so they were looking at it within this this study, things about what are the conditions and capabilities of unmarried parents, what's the nature of relationships between unmarried parents, how do children born into these families fare, and are there policies or conditions that affect families and children. So for this particular study, then there were about 2,150 adolescent mother pairs coming out of this national sample. And so standard measurements were used. So there for adolescent depressive symptoms and anxiety symptoms, as well as they looked at maternal depression, again, using standardized tools. And then they looked at adolescent gender defined as sex at birth. And so what were the main findings? So basically, the logistic regression models were looked at between adolescent gender and interaction with maternal depression. And when adolescents are around age 15, maternal depression was associated concurrently with significantly higher adolescent depressive and anxiety symptoms. But in the title of this talk is the relationship is substantially larger for daughters compared to sons. And look at the left for depressive symptoms. Girls with depressed mothers experience higher predicted depressive symptom scores than boys with depressed mothers. And the difference in depressive symptoms reported by adolescents with depressed mothers compared to adolescents whose mothers were not depressed was also larger for girls than for boys. And then looking to the right on anxiety symptoms, this was also the case, but predictive mean depressive and anxiety scores for both girls and boys, including those with depressed mothers and those with mothers who were not depressed, was relatively low. So it's important to note there. And so this is a lightning talk, so I gotta get right to the point here. So what are the conclusions? Well, adolescents, particularly girls then, are affected by exposure to maternal depression.
One minute now.
We found there was a possible spillover effect. And so it's really important to note that adolescent treatment of these symptoms may actually be beneficial to mothers and vice versa. So the findings underscored the importance of mental health treatment for both parents and adolescents, and ideally both. So we also, part of the recommendations were that school-based mental health programs can reach a substantial population of at-risk youth, and that these are important safety nets, and in particular, such programs should consider targeting adolescent girls, and especially those in disadvantaged communities where girls' risk of internalizing symptoms is even greater. So that's all we have for our presentation. Happy to take questions. I'm sure Dr. Livings can answer as well. Thank you.
Thank you, Melissa, for sharing with us such an important longitudinal study. I hope to have some discussion at the end of the third speaker. All right, we will move on to our next speaker, who is Dr. Vincent Cheng Hong Chen. He's a child psychiatrist and professor based in Taiwan and earned his PhD at the Institute of Psychiatry, Psychology and Neuroscience, King's College London, University of London. He also founded the Taiwan ADHD Family Child Adolescent Association to offer education and support programs for ADHD caregivers. And in addition, he co-founded the Mentor We digital platform aiming to address disparity of child psychiatry services in Taiwan. I'm very pleased to welcome Vincent, who I know from his activities with me at the Pacific Rim College of Psychiatrists. So Vincent, over to you to talk about application of digital technology in the care of ADHD.
Thanks for introduction. Today I would like to talk about the application of digital technology in the care of ADHD in Taiwan. The ADHD is a neurodevelopmental disorder with a high prevalence long-term cause, but the treatment rate is relatively low in Taiwan. Adolescents can lead to several adverse outcomes such as suicide and accident. Our study demonstrated a strong link between ADHD and mortality, especially in cases of unnatural deaths. The treatment for ADHD relies on a multiple model approach. This includes the use of medication, behavior therapy administered by caregivers, and a specialized education program. From the model, you can see the importance of environment, such as family. So we have carried out the Taiwan ADHD family studies, and we found the mothers with ADHD children have a lower quality of life. Distressed mother showed less positive engagement in their parent-child interaction, and the effect of behavioral parent training show a moderate effect size post-treatment, but decreased to a small effect size during long-term follow-up. So the parenting training program requires ongoing and persistent support. So we launched the Taiwan ADHD Family Support Program and the association. The association has over diverse training programs for parents, teachers, and the children. To date, we have conducted over 1,000 sessions comprising a variety of activities involving 25,000 participants. The state satisfaction survey showed that 97% of participants feel satisfied for the program. The association is located in central Taiwan, and we are striving to expand the model to cover entire Taiwan due to the good results. In collaboration with the association and the innovative Mental We digital platform, we have launched a digital model for ADHD care. The goals aim to achieve the following objectives: reducing the inequity for assessing mental health support, offering both subjective and objective assessment, and providing continuous care. The digital system comprises 3 key components: Mental We video conferencing software, Mental We website app, and the cloud data analysis system. To ensure confidentiality, the team has developed its own video conferencing system to comply with HIPAA regulations, as most commercial systems fail to meet this standard. The platform can be used for online training, conference, and telepsychotherapy. On the website and app, we have incorporated more than 100 updated pieces of knowledge from important papers. We have created several online videos for a variety of topics, such as behavioral therapy. We offer live online training programs for caregivers, especially during pandemic. We have also developed a meditation app to assist children in regulating their emotions. We have created a Mental We Watch and a cloud analysis system to automatically record activity and the sleep pattern. From the data, you can observe distinct patterns for ADHD children and the non-ADHD controls both before and after sleep. Our validation study of Mental We Watch has demonstrated our ability to differentiate ADHD cases based on different patterns of activity, achieving a good AUC score. I have also developed a Chen ADHD scale in Chinese language and conducted a validation study which demonstrated good validity. We have transformed this scale into an app, enabling caregivers to assess children's ADHD symptoms anytime, anywhere. The APEC can automatically store and report scores to display long-term trends. Through a digital care system, we have been able to shift the care model from repeated cross-sectional to continuous care, transition from clinical-based to home-based care, and extended care from urban-based to anywhere cloud-based. We have applied this system to train caregivers in 6 child placement agencies and implemented a community caregiver support program in rural areas. The preliminary analysis showed a community program that more than 91% of participants are satisfied with the digital program. We have also identified trends of improvement in several domains, including satisfaction with children's behavior, self-efficacy, and the quality of interactions. We plan to enroll 1,500 caregivers and evaluate the outcomes of the digital intervention program over the next year. Please see the briefly short video of the system. This is scale you can easier to use and then come out the score with the long-term record of the trend. We have also body weight and BMI record since the drug side effect. This is the activity and the sleep report. This is for the review articles and the videos.
1 minute left.
This is the app for the meditation. You can see the inhale and exhale. And thanks for your listening. You can download the app of the Chinese version from the QR code. We will develop English version over the next year. And thanks again.
Thank you, Vincent, for your excellent presentation on such an innovative program for ADHD children in Taiwan. I'm sure there will be many questions that as a result of your talk. So we'll come to that at the end of the next presentation. So let me introduce our final speaker for this lightning panel. It's Dr. Daniel Hwang, who is a child psychiatrist and the Chief Executive Officer at Singapore's Institute of Mental Health. He's also the President of the College of Psychiatrists, Academy of Medicine Singapore, and an adjunct associate professor at all 3 medical schools in Singapore. So he's a very busy person, and he will talk to us today on the digital mental health in Singapore. Over to you, Daniel.
Thanks, Jean. It's been a while. We haven't met, and so happy to be here. Let me start us off by, and I know it's. Can you see my screen? Just to check in. Can you see my screen?
Yes.
Yes. Okay. So I'm going to start us off with a metaphor. The Institute of Mental Health is a hospital. It's like a tree in that along this river of life, and on that river are the inhabitants of our countries. Whether you are living well or you're living with illness, you come to crisis, and maybe hopefully you can leave well as well. In that crisis care part, most of our hospitals exist, like that tree, IMH, whether it's a general hospital or a specific psychiatric hospital like ours. But our goal really is to prevent mental illness and promote mental health. Now, before you talk about digital mental health, you really need to think of the strategy. How can we get our healthcare systems, our mental health ecosystems into the next era and into the next generation? Now, we have a strategy in Singapore called Beyond 100 because IMH is 95 years old at this point. And along this river of life, we are focused on crisis care. But actually, most of the time, we are hoping and wishing that we could do work upstream, whether it's persons with mental illnesses who are at risk, or persons who have developed mental illnesses but are, we're able to deal with early on and have timely support and early intervention. But how do we go upstream? Now, a tiered care or step care model is probably required, and most of you must be familiar with this. Majority of the population are healthy. Only 1 in 7, or depending on, well, in Singapore, it's 1 in 7, but elsewhere in the world, it could be 1 in 5 or 1 in 4 may develop a mental illness in their lifetime. They may also, of course, need to deal with stresses of life. In that healthy population, where 80% of the population may sit, what needs to be done? And then people at risk, then people who are potentially requiring support services from the mental health service industry. Now, we've divided it into 3 main areas: population health, tertiary care, and recovery care for persons with mental illness who are now stable, having been treated. Now, strategies for each of these components are important. In population health, it's about mental health literacy. For tertiary care, perhaps it's about integration, both inpatient, outpatient, and medical care. And then for recovery care, it's about rehabilitation and collaboration with community partners. All of this require enablers to allow this to happen across the population. And that's where digital comes in, because digital can allow us to democratize, create equities across our populations, whether it's in mental health literacy, in coordination of care and integration, or whether it is in psychosocial rehabilitation and collaboration with partners. Now, let me give you some examples of what we've done in Singapore. For population health, we've developed a number of websites and portals. Mindline.sg is a illness-based early intervention, identification, and supports for the population. We also have Mind.sg, which is more towards health promotion and mental health, mental wellness type of portal. And then we have tools within these systems, whether it is specific intervention, whether it's like a treatment for ADHD or picking up depression in young people, that would be separate. Moving into the tertiary care side of the house, we have telehealth, telepsychiatry. That's me sitting in my office. In fact, that's where I am now, giving you this very quick a brief overview. And then in recovery care, can we monitor and support and looking at digital phenotypes to see if you can pick up issues well before they are problematic and support them as they live their lives back in the community. I'll give you some examples of what we've done in Singapore as a potential for work that could possibly extend to populations. One, for example, is this monitoring. So heart rate variability can predict depression and its relapse. There are also studies that have been initiated to look at specific digital phenotypes and trying to understand emotions through non-intrusive, objective monitoring, which is does not require you to respond to an app, for example. But all this is still in research. How do we sort of scope and frame all of this together? Because we're talking about artificial intelligence and predicting. There are ethical and legal issues. So you must have a framework, whether it is guidelines, ethical guidelines, or even laws. So in, I think there was a question earlier about how do we deal with the apps, the 300,000 apps that exist in health and 10,000 that exist in mental health. Well, we probably need some way to look at apps, not in the traditional randomized controlled trial, because only about less than 1% of apps actually get evaluated. Then we need guidelines, whether it's ethical guidelines or specific guidelines for use of tele-psychiatry, collaborative telehealth, and so forth. And then we need laws. Telemedicine services need laws that help to regulate and make sure that people are kept safe. And then finally, as you start to conceptualize some of this, proof of concept is important, proof of value, and then mainstreaming or scaling to sustainability. All of these things require some kind of planning. So this is an example. Yep. This is an example of what we did in Singapore, where we take a 3-year period to try and implement something from proof of concept all the way to mainstreaming for telepsychiatry. So what is the future? This is my probably the most important slide. The future challenge really is thinking about psychiatry without necessarily psychiatrists, thinking of hospitals without beds, thinking of treatment without clinics, and last but not least, research without researchers. Why do I say that? Because I think we need to look at new ways of looking at information. We actually have I had taken out my earlier slide because I ran out of time, but I thought it's important to have information and data available. And I think it needs collaboration. And I put, many of these organizations here, partly because it requires a combination of government, the people sector, and as well as the private sector, and to come together to develop something like this for the future. Thank you very much.
Thank you, Daniel, for a fascinating talk and sharing the concept of applying digital mental health in the course of mental illness as well as its recovery. So we now have, I think, about 7 or 8 minutes left for questions with the panelists. So if the panelists can just switch on their video, Melissa, yes. Good. All right. So I might kick off with the first question for Melissa. With the results that you have presented today, what do you think would be the implications of, in terms of practice, with the finding of increased mental health problems in girls with depressed mothers?
Yeah, so I think it's important for us first to recognize that girls may be more disproportionately affected than boys when their mothers are also, experiencing these symptoms. Therefore, it gives us some insight into policies that can be developed that may be able to especially target girls. And also, as we talked about the spillover effect, that there may be some benefit in ensuring for adolescents in ensuring that mothers are treated and vice versa.
Thank you. And do you think that there will be further up, the next stage of that research? Like what else do you think we need to kind of further research to address the gap?
Yes, so I think there were a lot of next steps that came up in this research. Clearly, there's more work that needs to be done in other contexts, right? There's a need to better understand whether the impact is greater at certain ages. For example, so it doesn't matter if it's current depression versus a mother having experienced depression earlier, but maybe has already been treated, or if at different age ranges of the children and adolescents, if there's also a differential impact. So there's still quite a lot of work to be done in this area, but we found the results to be interesting, and definitely more exploratory studies should be conducted.
Thanks, Melissa. I'm sure our two other panelists, Daniel, Vincent, who are both child psychiatrists, would be very interested in this finding. So a question for you, Vincent. With such the innovative ADHD program, what advantage in terms of the clinical outcome, has there been studies done to compare a group of children who has used the benefit of this application versus another group that perhaps didn't have the benefit of this particular program?
Thanks for the important question. We now just in the initial stage. We just launched 2 months ago for the community-based program. So we try to do the first time for the follow-up for the participants, the comparison before the use and after use. And the second stage, just as you mentioned, we will try to do some kind of comparison trial to do some patient with some family with the program, and some persons without. This is the next stage.
Thank you, Vincent. I'm sure we will all look forward to see the results of that research published.
Yes.
And Daniel, that's an excellent sort of concept to try to implement, to try and use the digital mental health to assist people in their recovery process. I wonder if you can comment in terms of the uptake of this program, particularly for people with chronic mental health problems and chronic disability, in terms of engaging them in using digital mental health.
Yeah. Thanks, Chi. I'll tell you this. You know, when we first started, people were saying, no, our patients will not get onto digital platforms. But the reality is that digital has come to them. Everyone in Singapore has at least one cell phone, if not more. And every cell phone is a huge sort of device that allows that democracy. And what we need to do is to not get people to sort of fill in forms and do things, but actually collect that data seamlessly in the background as they go about their daily activities. So we have done a study with schizophrenia that certainly suggests that in chronic schizophrenia, just some monitoring will allow us to identify their issues, predict relapse if possible, and therefore allow us to intervene earlier and keep patients out of hospital. There is a burning platform today. Our hospitals are full. Singapore doesn't have enough psychiatric beds. We're trying to build them, but it takes a while to build a psychiatric bed. And to get services in play to prevent some of this, I think digital is one sort of solution. And I see that as an entire ecosystem. Apart from recovery, I mean, the population health side, you can do so much for example, in identifying the families of depressed mothers, for example, and trying to support them, or identifying individuals with ADHD and allowing them to sort of pick up skill sets while they are in school, going about their daily business, rather than having to get them to clinics. And digital actually provides you, it's an enabler. It's not a direct solution. The solutions still have to come in terms of what needs to be done. But to get there, we need to have that framework. And I think the other piece that we didn't get a chance to talk a lot about is about the sharing of data, whether it's research data or other kinds of data, and creating data analytics platforms, which is quite important, particularly in population health.
Thank you. That's an excellent point to finish on, really, Daniel. I really appreciate the three presentations. It really bring into focus the value of and the potential of using digital mental health to be applied across the lifespan, across the recovery process. So I'd like to really ask the audience to join us in thanking our 3 panelists with the 3 excellent presentations. So thank you very much all. And now over to you, Jill. That's the end of the lightning panel talk number 3.
Yeah, thanks so much, Chi, and thank you so much, Dr. Withers, Dr. Chen, and Dr. Hwang for your excellent talks. I think it was a fantastic note to end the forum on, and I really like the sentiment of digital mental health being democratizing. I think that's so optimistic and really forward thinking in terms of where we go from here in terms of mental health, digital mental health, and equity. And Dr. Chen, I think I might download your app just for the pufferfish meditation. It's very adorable. So this that was our final panel. So we're just going to take a few moments to wrap up and do some final reflections with Digital Hub exec. I want to start by sincerely thanking all of the speakers today for taking time out of your busy schedules across different time zones, and many of you for navigating our very short time limit. We wanted to make sure that we didn't have to pick and choose from all the amazing work that's going on across the region, and really did a good, and to really highlight a lot of the best practice. So I want to sincerely thank the speakers for your efforts today and for joining us. I also want to thank the members of the Digital Hub exec for your excellent moderation today. And once again, to thank Rosie and Vanessa for your support, Rosie especially, and all your efforts in coordinating this event. And to the attendees, thank you very much for joining us. Again, also across time zones and taking time out of your busy nights or days to join us. I'll just give a couple of remarks to wrap up and then pass it over to Ray and the other exec members. But just wanted to say how inspired and encouraged I am by hearing all the excellent research, policy, and implementation efforts that are happening across the region to advance mental health access, equity. It's been really fascinating and really inspiring and really nice to hear from you all. So I'm really grateful. We also hope that this forum initiates additional collaboration, and the Digital Hub is really about networks and networking and building capacity. And we hope that this will facilitate additional collaboration, that it will lead to networking and more in-depth sharing of best practices, and really hope that we can kind of build on the momentum of this forum going forward. And we're only as strong as our network as the Digital Hub. So if you're not already a member and you'd like to get involved or collaborate, please do reach out and get in touch. Ray, I'll pass it over to you and then open it up to everyone else.
Yeah, no, that's great, Jill. Again, thanks to all the speakers, some wonderful presentations by everyone. And to all the participants, thank you for your time. But I do want to reiterate as well that we don't want to stop with this webinar. We want to continue to engage you. We'll be sending around a feedback form, of course, because we'd like your opinions as to what worked and what you would like to see different in future forums, but also how we can best relate and interact with you to move this agenda forward. So thank you very much for your participation.
I just saw a question in the Q&A about people wanting to reach out to speakers with additional questions. If you would like to get in touch with Rosie or with me, I'll put my email address in the chat. Please feel free to reach out and I can facilitate connecting you with speakers or pass along your questions to them. And I'm sure we'll also be sharing a video link of the forum. So that will be available as well.
Bill, just a comment. Thank you so much for your leadership in putting this together. You're really a tour de force in the APEC Hub, pulling different themes and speakers in some of the activities we've been doing. Without you, we would be much less. And today was a really great success. Thanks so much to you and to Rosie too, for although she's only been with us for a short while, she's been doing a really great job. I really appreciate it. Thank you so much.
echoing that, Andy. And just for me, one of the resonant themes of our time together was the centralization of the importance of lived and living experience of people with mental health conditions, and in particular thinking about people who have been historically marginalized or that we haven't reached well enough through services and implementation science activities. And that really feels that I believe that that's at the heart of what we're doing. And I really appreciated that central theme today.
Thanks, Erin. Thanks, Andy. So unless there's any other questions, comments, or thoughts, I think we'll wrap up. And again, a huge thank you to our speakers and to all the attendees. Thank you for taking the time to join us. And please stay tuned for next steps and for the feedback form that Ray mentioned. And enjoy the rest of your evening or day, depending on where you're located. Thanks.
Take care, everyone.